Okay, let's dive into one of the most critical and honestly trickiest challenges we face as clinicians, diagnosing adrenal insufficiency. It's a condition that can be incredibly subtle, but the consequences of missing it are life-threatening. So in this explainer, we're going to lay out a really clear, practical roadmap for navigating this diagnostic journey. And this right here is the heart of the problem, isn't it? We're talking profound fatigue, nausea, weight loss. These symptoms could be just about anything. That's why the absolute key is to maintain a high index of suspicion. And that's exactly what we're here to sharpen today.
So here's how we're going to tackle this, step by step. First, we'll get into the why, the basic pathophysiology. Then we'll zero in on the clinical clues you need to be looking for. After that, we'll walk through the labs, figure out how to interpret the results, and finally, cover the critical, life-saving actions you need to take when a crisis is on the horizon.
All right, first things first. Before we can even think about diagnosing it, we have to understand where the problem is along the HPA axis. Where's the breakdown happening? Turns out there are really three main points of failure. So think of primary AI as a total factory failure. The adrenal glands themselves, the machinery on the factory floor, they're just broken. The pituitary gland can be shouting orders, sending ACTH all day long, but if the equipment is offline, no cortisol is getting made. Simple as that.
Now with secondary AI, the factory, the adrenal glands, is perfectly fine. It's ready to go. The problem here is with the factory manager, the pituitary gland. It's just not sending out the work orders, the ACTH. So you have these perfectly capable adrenal glands just sitting there, totally idle, waiting for a signal that never arrives.
And taking it one step higher up the chain, you get tertiary AI. This is a problem with central command itself, the hypothalamus. It's not releasing CRH, which is the very first signal that kicks off this whole cascade. And what's really critical to remember here is that the number one cause is us. It's iatrogenic, from prolonged use of exogenous steroids that shut the whole system down from the top.
Okay, so with that framework in our back pocket, let's get back to the clinic. How do we actually start to pick up the trail of adrenal insufficiency in a real patient? Well, it usually starts with those really broad symptoms before we can narrow our focus to some very specific signs. We've all seen charts that look just like this, right? The symptoms are incredibly nonspecific. That fatigue isn't just being tired. Patients often describe it as this bone-deep exhaustion. And that salt craving? That's a really subtle but super important clue that should make your ears perk up. It points directly to the mineralocorticoid deficiency that we see specifically in primary AI.
Now this is where your suspicion starts to harden into a real diagnostic possibility. Yeah, hypotension and hyponatremia are common flags, but the real game changers, the things that separate the signal from the noise, are hyperkalemia and hyperpigmentation. If you see those, primary AI should immediately rocket to the top of your differential list. Why? Because they're both caused by processes that are completely unique to when the adrenal gland itself fails.
And this quote just nails it. This is the classic triad you have to burn into your memory. If you find this combination of things, you have to act. It's not optional. You have to investigate for primary AI until you have proven, definitively, that it's not there. Okay, so your suspicion is high. You've got a potential case right in front of you. What's the immediate, practical next step? It's all about ordering the right tests, and just as important, at the right time.
Look, timing is absolutely everything here. Cortisol follows a diurnal rhythm, right? It peaks somewhere between 6 and 8 in the morning, so drawing a random cortisol in the afternoon is pretty much useless for screening. The key is to get a coordinated 8 a.m. draw for both cortisol and ACTH at the same time. That single blood draw gives you a perfect snapshot of the conversation happening between the pituitary and the adrenals.
And from that one draw, you're basically looking for one of two patterns. In pattern A, you've got low cortisol, but the ACTH is sky high. That's the pituitary screaming at an adrenal gland that just won't listen. It's classic primary AI. Then you have pattern B, low cortisol, but the ACTH is also low or maybe inappropriately normal. That tells you the problem is upstream. The pituitary isn't sending the signal, which points you squarely towards secondary or tertiary disease. So you've got the labs back, you're staring at a cortisol number. What does it actually mean? Let's break down the thresholds because where that number falls is going to guide your very next move.
All right, let's make this simple. If you get a morning cortisol this low in a patient who has the right clinical picture, that's it. You're done. You have your diagnosis. Your next step is not more testing, it's immediate treatment. You can figure out the underlying cause later once your patient is stable.
Now this range,
This is the gray zone. This is the diagnostic headache. A result here doesn't confirm AI, but it doesn't exclude it either. This is exactly the kind of patient who needs dynamic testing, specifically an ACTH stimulation test, to really see what their adrenal reserve looks like. On the flip side, if you get a morning cortisol above this level in a patient who isn't critically ill, you can pretty much rule out adrenal insufficiency. This is a clear stop sign. You can confidently move on and start investigating other causes for their symptoms.
We've now arrived at the most critical part of our roadmap. This is where a fast, correct decision can literally be the difference between life and death. So what do you do when you suspect a full-blown adrenal crisis?
There is one single, non-negotiable rule here. You treat first and you diagnose later. If your patient is hemodynamically unstable and AI is on your radar, you do not wait for a cortisol result to come back from the lab. You give 100 milligrams of IV hydrocortisone and you start aggressive fluid resuscitation. Period. No hesitation.
But what if you're in that tough spot where you need to treat urgently, but you still really want to get a definitive diagnosis? Well, here is a fantastic clinical pearl. Use dexamethasone. It's a potent glucocorticoid, but it won't cross-react with the cortisol assay. This lets you treat the patient immediately while still being able to run an accurate ACTH stimulation test later on. It's the best of both worlds.
And we always have to come back to this. The most common reason for a suppressed HPA axis in the entire world is the steroids that we prescribe. You have to take a thorough medication history, and don't forget to ask about things like high-dose inhaled or even topical steroids.
So, let's say you do diagnose a case of primary AI. What's the most likely culprit? Well, in developed countries, the answer is overwhelmingly autoimmune disease. In about 80% of cases, it's the body's own immune system that's attacking and destroying the adrenal glands.
And this number right here, this is why this entire diagnostic roadmap is so incredibly important. Even in patients who already have a diagnosis of AI and are on treatment, an adrenal crisis still carries a 6% mortality rate. The stakes are just incredibly high, which is why that early recognition and prompt action we've been talking about are absolutely paramount.